Welcome back, students, to part 86 of our IPDRG Masterclass. I'm your host, Harshal. Today, we're diving into a fascinating area where high clinical complexity totally collides with high financial stakes. We're talking about the advanced surgical DRGs for major diagnostic category 01, which covers the nervous system. We've got an amazing explainer lined up today, entirely focused on decoding the structural logic behind neurosurgery and spine procedures.
But before we dive into all that, a quick reminder. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Your support is absolutely crucial. It really helps us keep these deep dive masterclasses coming your way.
All right, so let's do a quick recap. In part 85, we mastered the medical side of MDC-01, right? We looked at how principal diagnoses, like strokes, basically drive the DRG assignment when there's no major operating room procedure happening. But the second that patient is wheeled into the OR, well, the whole grouping logic flips on its head. And that is exactly the puzzle we're going to decode today.
Here is our roadmap for today's explainer. We'll be covering 1. MDC-01 surgical partitioning, 2. ICD-10 PCS code structure precision, 3. A root operations deep dive, and 4. Neuro updates and compliance.
Let's jump right into Section 1, MDC-01 surgical partitioning. So if you picture the fundamental rule of MSDRG grouping, it's basically a massive hierarchy. Within most major diagnostic categories, including MDC-01, cases are first split into two main buckets, medical and surgical. The golden rule you gotta remember here is that if a procedure happens that meets the CMS definition of a major operating room procedure, that procedure literally overrides the medical diagnosis. It yanks the case right into a surgical DRG. And once you're in that surgical partition, the MSDRG grouper logic engine looks at your secondary diagnoses, your CCs and MCCs, to drop the case into a DRG triplet. This triplet structure, which is with MCC, with CC, or without CC/MCC, is what dictates the final payment tier for major high-volume procedures like craniotomies or ventricular shunts. It directly drives that base relative weight.
Okay, moving right along to Section 2, ICD-10 PCS code structure precision. Now, to actually get to that surgical DRG, your procedure code has to be absolutely flawless. The ICD-10 PCS system is built on 7 distinct alphanumeric characters, right? CMS built this specifically for inpatient hospital procedures, and unlike the medical side, this system is entirely combinatorial. There are no decimal points anywhere. Every single character represents a very distinct aspect of the surgery. So you start with the section, medical and surgical. Then the body system, which for our neuro cases is often 00 for the central nervous system. Next up is the root operation, and this is huge because it defines the true objective of the procedure. From there, we need pinpoint precision on the body part, the approach the surgeon used, the device left behind, and any qualifier. I mean it. Getting just one of these characters wrong can literally drop your case out of MDC-01 entirely.
When you're translating clinical notes into these codes, you always have to sequence the principal procedure first. That's what ensures the correct MSDRG assignment. And you absolutely must verify things like the approach directly from the operative report itself, not just a quick clinical summary. For example, in advanced neurosurgery, whether an approach was open versus percutaneous endoscopic dramatically changes your fifth character. Your clinical documentation, the OR reports, the anesthesia notes, the whole shebang has to clearly back up every single one of those 7 characters if you want to survive an audit.
Which leads us perfectly into Section 3, our root operations deep dive. This is where we see the most coding errors in MDC-01, hands down. In the medical and surgical section, root operations describe the main goal of the procedure. And 2 of the most easily confused are excision and resection. Mixing these up is basically a fast track to a pair denial. Remember, excision is just cutting out a portion, kind of like a biopsy. Resection, on the other hand, is the complete 100% removal of a body part. Now, both excision and resection allow the surgeon to use any sharp instrument. Could be a scalpel, a wire, even a bone saw. The real determining factor here is the anatomical subdivision. The guidelines are super explicit about this. A resection of a specific anatomical subdivision must be coded whenever possible over an excision of a less specific part. So if a neurosurgeon completely removes a distinct lobe of the brain, you have to code the resection of that specific subdivision. And beyond just excision and resection, advanced neurosurgery relies heavily on the root operation extirpation for clot removals, like in an endovascular thrombectomy for a stroke. And they use restriction for things like aneurysm clipping. Getting these right is absolutely non-negotiable.
All right, let's shift our focus down to the spine. Spinal procedures are incredibly high volume and high complexity. The main root operation we see here is fusion. This means joining together portions of an articular body part, like 2 or more vertebral bones, using devices or internal fixation to make that joint totally immobile. But here's the critical part for coders. You have to figure out if the fusion is being driven by a neurological deficit, like spinal cord compression. If it is, it stays in MDC01. But if it's strictly a musculoskeletal issue, boom, the DRG gets bumped completely over to MDC08. So when auditing these, always ask yourself, what's the specific vertebral level, and what exact device type was used? Let's actually break down the logic to confidently build a lumbar spinal fusion code. Think of it like a recipe. Step 1, Section 0 for medical and surgical. Step 2, root operation is fusion. Step 3, determine the approach from the operative note. Let's say it's open. Step 4, identify the device, like an autologous bone graft. Following this structured path right across the PCS tables lets you accurately build a code like 0SG00ZZ. And don't forget, if multiple vertebral joints are fused, you have to code a separate procedure for each joint using a different device or qualifier. Precision is literally everything here. Okay, let's move on to our final segment, Section 4, Neuro Updates and Compliance.
Knowing your codes is great, but it's really only half the battle. You also have to know the current regulatory landscape to defend your codes. Take the recent HC Pro updates regarding MSDRG revisions, for example. They actually revised the titles for craniotomy DRG 023 and 024 to explicitly include major device implant and epilepsy with neurostimulator. This isn't just CMS playing with words, it's a reflection of how clinically important and expensive these specific devices are becoming in neurosurgery. So making sure your approach and device characters are flawlessly documented is exactly what locks your case into these specific high-weighted DRGs. Now here's a surprising clinical nuance that trips up even the most veteran documentation specialists. Have you ever seen a case where a patient comes in with acute stroke symptoms, they get TPA, and then their CT scan comes back totally clear? It's clinically known as an aborted CVA. Well, guess what? According to our guidelines, an aborted CVA treated with tissue plasminogen activator absolutely can and should still be coded as a CVA. Crazy, right? But the logic is that they actually did suffer a cerebral infarction. Even if the brain damage isn't visible on a macro level on the CT scan, the microscopic changes are undeniably there. When it comes to audit defense, a lot of the focus on post-op neuro patients is about capturing those secondary CCs and MCCs, like cerebral edema, CSF leaks, or central diabetes insipidus. But a huge target involves fluid imbalances. Specifically the relationship between hyponatremia and SIADH. That's the syndrome of inappropriate antidiuretic hormone secretion. Our sources explicitly point out that both of these conditions fall under an excludes one note. That means you literally cannot code them together. You must only code SIADH. And to defend this in an audit, you can't just slap the code on the claim and call it a day. You have to justify it with real clinical indicators. Did the diagnosis require therapeutic treatment? Did it extend their hospital stay or require extra nursing care? These are the exact guidelines you have to use to validate those secondary diagnoses and defend your DRG grouping. So, to sum up today's masterclass, accuracy in that 7-character ICD-10 PCS structure is completely non-negotiable. Your ability to correctly tell the difference between root operations like excision, resection, extirpation, and fusion directly dictates whether the MSDRG grouper logic drops your patient into the right surgical tier within MDC01. That precision is what ultimately drives facility reimbursement, and it makes sure the true severity of the case is accurately reflected. Next time on Decode Healthcare, we are going to be switching gears entirely. We're moving from the nervous system to the incredible complexities of the gut. Make sure to join us for part 87, where we'll be doing an advanced medical DRG deep dive into major diagnostic category 06, the digestive system. But before we go, I want to leave you with a provocative question to take back to your teams. Think about this. When a neurosurgeon documents a procedure, are your clinical notes truly precise enough to defend your chosen root operation, character by character, in a rigorous payer audit? Because the answer to that question really is the difference between revenue integrity and a very costly denial. Thank you all so much for joining me for part 86. As always, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Herschel. Class dismissed, and I'll see you in the next explainer.